arthroplasty. Thank you.
Good afternoon again. I'll be talking about heterotopic ossification following lower limb arthroplasty. HO, or heterotopic ossification, is defined as a trabecular bone formation outside of the skeletal structure, occupying space in soft tissue where ideally it should not be existing. It does occur in between muscle planes and not within the muscle fibers themselves. It does not interfere with configuration of the periosteum. The causes are multiple, neurologic, genetic, but the most common was pertinent to our practice is the traumatic. When we do the soft tissue dissection, blunt trauma, hematoma, persistence of debris in our surgical wounds. What are the risk factors if the patient had previous heterotopic ossification, whether in the ipsilateral or contralateral hip? Patients with rheumatoid arthritis and ankylosing spondylitis, patient had got previous revision toe hip arthroplasty, hypertrophic version of the osteoarthritis, or diffuse hypertrophic skeletal hyperostosis, osteonecrosis, and Paget's disease. The mechanism is not clearly known, but it's thought to be that it's due to the inappropriate differentiation of pluripotent mesenchymal stem cells mediated by prostaglandin E2, also subsequent to upregulation of growth factors, particularly bone matrix protein type 4. It's possible that inflammation and cell death do induce the above mechanisms. The incidence is reported much more higher in total hip arthroplasty, anything between 5 to 90%. However, the clinically significant ones, which are the Bruker classification of type 3 and type 4, have only been seen in 3 to 7%. Similarly, in total knee replacement, although HO have been reported as up to 40% of cases, the symptomatic ones have only been reported in 1% of cases. So what is Bruker classification? It's based on anteroposterior radiograph of the pelvis or the hip. Type 1 or grade A is bone island in between the hip joint, which is less than a centimeter in size. Type B is bone spur across the joint, which are more than a centimeter apart. Type 3 or C is bone spur, which are less than a centimeter apart, and a complete bony ankylosis is type 4 or grade D. This classification has been challenged by multiple authors in the literature, and the main concern was the decreased inter-observer reliability of 50% or less, particularly in type 3 and 4, and therefore the group of HSS, led by Dr. Salvati, came up with a modification where they recommended type A having a bone island of at least one bone island of 1 centimeter or less. Type B would be bone island as well as a bone spur that are more than 1 centimeter, but they are more than 1 centimeter apart. And what they did is they combined type 3 and type 4 in classification C, having a bone spur less than a centimeter apart or a complete bony ankylosis. And their recommendation and proposition for this was to increase the reliability in type C, and particularly when you use this to compare the different type of prophylaxis and treatment. Most of the patients are not very symptomatic. If they are, the symptoms are very ill-localized with pain and warmth. They may have some loss of range of motion, particularly towards the Bruker type 3 and 4, and this will be either in terminal flexion or terminal abduction. In terms of total hip arthroplasty, although it has been shown that the lateral approach has a higher incidence, but the clinical significant one, which is the type 3 and 4, are not significantly different between both approaches, and overall incidence is very low, 3.4%. Whether you use a cemented or cementless total hip arthroplasty, the incidence of HO does not differ. The best treatment is prophylaxis, and there are two major prophylaxis types. One is by non-steroidal anti-inflammatory medication, and the other is by radiation. Endomethacin has been well established in the literature to be given as a prophylactic for those patients who you identify as an at-risk population. The dose is 25 milligram 3 times a day for 5 to 6 weeks. It works through directly inhibiting prostaglandin E2 mediated bone remodeling and differentiation of osteoprogenitor cells. But obviously all of us understand the concern of endomethacin or naproxen is their high gastrointestinal side effect. It may also cause non-union, particularly if you're using it in cases of revision hip where retrocontract osteotomy has been done. And if you're using a cementless implants, which a lot of us are doing these days, there could be concern about bony ingrowth in these cementless implants. They have been shown to lower the incidence of HO by half to 2/3 of cases. In order to take the concern of the GI side effect, the group from Italy compared the effect of celecoxib, which is a COX-2 inhibitor, a much more selective type of non-steroidal anti-inflammatory, and they showed that there was no difference in the incidence of hydrotopic ossification, particularly type 1 and 2, and patients who received celecoxib had much more lesser side effects, which means their compliance was far more better. Well, what about radiotherapy? All the different studies have tried different dosages, timing, and duration. The acceptable dose is 7 or 8 GY, single fraction given either 4 hours preoperatively or within 3 days postoperatively. The concern of radiotherapy is to shield the prosthesis, particularly if you're using a cementless variety, but if you do shield them, would that decrease the efficacy of the radiation? Also, if you had used a trochanteric osteotomy, it has been shown that a trochanteric osteotomy non-union is reported between 12 to 30% of radiated cases. Most important concern is the radiation-induced cancerogenesis, certainly not the bony sarcomas, but the testicular cancer have been reported even as low dose as 2.5 GY. Therefore, testicular shielding is a must for patients who will be receiving radiotherapy for HO prophylaxis. Whether you use radiotherapy or medical prophylaxis, I think both of them has advantages and disadvantages, although in this particular series, it has been shown that the significant Bruker 3 and 4 type of HO are much more less reported with radiotherapy compared to medical therapy. What about the treatment? If prophylaxis failed or there was no prophylaxis given, certainly medical and radiotherapy has no role in treatment of these HO bony islands. The best thing is to do a surgical excision followed by prophylaxis. You got to wait till the HO has matured, which means that you got to do serial bone scan till the bone scans are cold, and then in that case you got to go in, be very careful of your approach, do not go within the muscles, go in between the muscle fibers and not through them, get to the bone, stay on the bone, and you'll be able to identify a very clear interval between the heterotopic ossification bony cortex and the native bony cortex, and you can then go in that interval, hit your curved occiput and flip it out from there. Don't forget to give the patient postoperative prophylaxis, whether medical or radiotherapy. This is a case example of my own. This patient had a previous total arthroplasty through a trochanteric osteotomy, underwent revision. As you can see, the staples were still in and started developing heterotopic ossification, went all the way to develop Bruker type 4. Surprisingly, this patient is completely asymptomatic. He's very happy. He can sit on the ground as well. So not every radiologic heterotopic ossification means clinically significant HO. Some new horizon, there's an agent called Noggin, which is a BMP antagonist, which has downregulated. So the BMP antagonist is downregulated. If you supply or the patients are administered Noggins, that might help in preventing HO. Pulse electromagnetic fields have also been shown to be of positive hopes in the field of minimizing HO. So in conclusion, I think we got to identify the at-risk population. Obviously, not every total arthroplasty patients need to be given this prevention. I think subconsciously, every total hip arthroplasty patient is given some kind of non-steroidal anti-inflammatory. If you do have to do a specific prevention, you got to choose between medical and radiotherapy. If you got to surgically excise the HO, then you got to wait till they have matured, document that by cold bone scan, and follow that with a prophylaxis so that they do not get a recurrence. Thank you very much.
Well, the session